We're going to go ahead and get started. I wanted to welcome everyone to tonight's webinar. I'm your host, Dr. Lorne Lavine. We had a great turnout this evening, close to 1,600 people that registered for the webinar. A lot of you are already here. I'm seeing lots of people logging in over the next couple of minutes as well. I'm going to do a little bit of housekeeping first. I'll introduce our speaker, and then we'll get to the presentation. Of course, I hope that everyone is staying healthy and safe. And I know it's been trying times for a lot of offices. Most of the offices that I work with are about back to 70–80% of normal. So I know a lot of you are on the road back to recovery, and we hope to see that as well. I'm going to speak for a couple of minutes. I want to make sure that Dr. Kosinski can speak for as long as he wants. We also want to make sure that we have time at the end for questions. Most of you have been on the webinars in the past. You kind of know the protocol. We're going to do the bulk of the webinar. Kurt from Golden Dental Solutions is going to come on and make a special offer, and then we're going to do the Q&A session. On your screen, you have a GoToWebinar control panel where you can type in the questions. With 1,600 people, we obviously can't take verbal questions, but as you see stuff that maybe you have some questions about, just feel free to type the question in. We try to get to the questions in the order that we receive them. One fair warning is that with the number of people that we have on this evening, we often don't get to every single question. I can see the questions as they come in. I'll consolidate some of them and try to bulk some of them together. But if we didn't get to your question, I apologize. It's just impossible with time restraints. This webinar is recorded. Shockingly, yes, we did know there was a debate tonight. We didn't know when we planned the webinar, so I know that Tim is going to get through the bulk of his content before the top of the hour. When he's done, Kurt will come on to make a special offer, and then I'll handle the Q&A. If for some reason that you want to, take off at the top of the hour to watch the debate, where we won't be offended, because it's recorded, that recording goes out to everybody. So, as long as you'll be able to listen to the whole presentation and be able to leave if you wanted to, if you weren't all that interested in the Q&A, but it is recorded, so it will go out sometime in the next day or two as well. Same thing for CE. As long as you're on for the bulk of the webinar, the content portion, Golden Dental Solutions is providing CE. You have to stay for, like I said, the bulk of it, but and that normally takes a little while to go out. As you can probably imagine, with 1,500 plus people, it can take a couple of weeks to get it all out, but please be patient. I always get that question, what about the CE? There's no test to take at the end of the webinar. You don't have to do anything. As long as you're here, we will send out the CE for you. So with that out of the way, I wanted to introduce our very special speaker, which is Dr. Timothy Kosinski. He's been with us a few times before. Tim is an affiliated adjunct clinical professor at the University of Detroit Mercy School of Dentistry. He serves on the editorial board of Reality, which is the information source for aesthetic dentistry. He's the past editor of the Michigan Academy of General Dentistry. He's currently the associate editor of the AGD journals, and he was also named editor of Implants Today recently. He's past president of the Michigan Academy of General Dentistry. He's done most of his training in Michigan. He got his DDS from Detroit Mercy Dental School. He got his mastership in biochemistry from Wayne State University. He's a diplomat of the American Board of Oral Implantology and Implant Dentistry. He's a member of the American Society of Osseointegration. He's a fellow of the American Academy of Implant Dentistry, received his mastership in the Academy of General Dentistry. I don't know where you put all these letters on your business card, Tim. I mean, I had to run out of space. He's received many honors, including fellowship in the American and International Colleges of Dentists and the Academy of Dentistry International. A couple of years ago, he got the Academy of Dentistry International's Humanitarian Award, which was for recognition of significant contributions to the enhancement of the quality of life in the human condition. He's a member of OKU and the Pierre Fauchard Academy. He was the University of Detroit Mercy School of Dentistry's Alumni Association's Alumnus of the Year in 2009 and 2014. He got the AGD's Lifelong Learning and Service Recognition. When it comes to implants, he's placed a few here and there, like around 14,000. He's a prolific writer. He's had well over 200 articles that have been published on surgical and prosthetic phases of implant dentistry. He's been a contributor to textbooks like Principles and Practices of Implant Dentistry and Dental Implantation and Technology. And if you were ever watched Noble Biocare's Noble Vision, then you saw him on there, and he lectures extensively. Tim, great to have you here. We're really looking forward to tonight's presentation, so take it away.
Thank you so much, Lauren. You always make me chuckle a little bit. Welcome, everybody. And again, we are going to respect everybody's time as far as the debate goes. We know how important it can be. And so I'll try to be thorough. We do have some videos. Golden Dent, the team at Golden Dent asked if you did want to follow along with an orange. Or as Lauren said, you can get a copy of this and practice your suturing skills. I'm going to try to make this really practical, and every time we do a program, I try to incorporate some of the newer things that I think may be useful. It's sometimes very challenging to take photography of each individual step, but I think the team does a very, very nice job of doing that. So today's topic is predictable suturing techniques for extractions, grafting, and implants. And Lauren, you did a nice job of introducing me. Many of my publications and video demonstrations you can find on my education website, drkosinski.com, and feel free to peruse that for more information or more specifics about some of the techniques that we are going to demonstrate today. So we came up with some objectives. We're going to talk about suturing techniques so that you can get predictable healing as long as we follow the certain rules. I'm not going to show you a ton of different techniques that I use. I'm going to show you, for those of you who heard me before, I try to be very practical. There's 1,000 ways of doing what we do, but I'm going to show you what I do daily in my practice that makes me successful and gives me predictability. And I think predictability is really the key. Time is money in your practice. And I know I always get a lot of emails from doctors around the country that where you have issues or problems. And so let's try to overcome those issues and get predictability so that we can increase our confidence and competence with these procedures. We'll talk a little bit about flap or reflection design. We'll talk a little bit about the different sutures. I don't use a lot of different types of sutures, but I do want to talk about it briefly. We're going to talk about different types of knots, and we'll practice those again on an orange, or you can do a grapefruit or something like that. And then we're going to show some clinical applications. This is not an implant training course. We've done several of those with Lorne in the past, and I'm really going to try to focus on flap design and suturing techniques to establish a proper foundation for your implant aesthetics or prosthetics. So, here we have a situation, a patient that presents with a missing tooth, and very common when a tooth is lost, bone shrinks up and in, sometimes results in a concavity, which can affect healing in a certain area. And so the flap design is very important. One thing that I do want to leave you with, for those of you who are incorporating implant dentistry in your practice, is it's imperative that you have at least a 2-millimeter band of attached gingiva on the facial aspect of all your implants. Many of us out there, including myself, have seen implant cases where the patient comes in and just says, it just doesn't feel right. It bleeds periodically and it just doesn't feel right. And we inadvertently always take a radiograph and we look at it and we go, oh, it looks like there's good bone around the implant. It looks like the abutment fits fine. Looks like the crown is well done, and we scratch our head. And the problem is when teeth are lost, bone shrinks up and in or down and in the lower jaw. And oftentimes, and I'll explain this to the patient, there's two types of tissue in the mouth. The attached gingiva is the gum in between your teeth, the pink gum in between your teeth, and the mucosa. And if gum shrinks up and in, say in this situation, or down and in the lower jaw, the mucosa will oftentimes follow, and which creates a bit of a problem periodontally around our dental implants, which can result in failure or complications later. So let's just go through the process here. We had a situation where the patient lost a tooth. There was a tremendous defect there. The site was grafted. And for those of you who have heard my grafting webinars in the past, know that I use different materials. We'll demonstrate a little bit of materials today, but we also know that healing always occurs from the apex towards the crest. So we get more mature bone at the apical portion, and this is a physiologic reaction. So I'm not overly concerned with the healing at the coronal portion, because I know that if I place an implant, I'm going to obliterate that anyways. What I really am concerned with is that I get initial stability. Initial stability with any implant system comes from the apical 2 millimeters of that implant. So just little things to remember as you're doing this. So one of my favorite instruments is the Orban knife, and this is a very sharp stainless steel blade of very precise angulation. And this is a product that I do purchase from Golden Dent, our sponsor today. And I think Kurt will come on a little bit later and have some specials. And I know that he has a grafting kit that we kind of put together, things that I use that you may want to purchase and incorporate into your practice. I think if you're going to do this type of surgery in your practice, you have to have the right tools, and you have to have the right tools at your fingertips. So having a kit in a nice little stainless steel tray, when you're going to do a procedure, tell your team member, you know, hey, we're going to do a graft today, or we're going to do a reflection. Bring me my my surgical kit for that. So what I'm doing is making an incision. I'm making sure that I at least have at least 2 millimeters of attached gingiva on the facial aspect. So I'm basically making a crestal incision, and you can see that I'm not making any vertical incisions here. And again, in some of my programs, I refer to this as an envelope reflection or an envelope flap, meaning if you had a number 10 size envelope and lifted the little V-shaped flap and blew into it, I have complete control of this reflection. Also, very, very important is I try not to ever incise into mucosal tissue if I can help it. If you incise into mucosal tissue, the patient will experience discomfort postoperatively. You will get histamine and prostaglandin release, and that will be uncomfortable for the patient. Number two, you also lose control of that reflection to a high degree, which can affect the healing and the eventual aesthetic result. So I'm reflecting the tissue with a periosteal, again, from the Golden Dent grafting kit, and you can see that I have complete control. Now I can elevate the periosteum all the way to the floor of the nose, all the way to the eye if I needed to, but I need to be able to see the defect completely. And here you can see how the bone shrunk in, making a concavity, which even if you weren't placing an implant could result in a aesthetic concern for any type of pontic. Now, again, this is not an implant program, so I'm not going to pursue the type of implant or anything, but every implant system on the market today has a series of drills. Normally, we start with a small diameter drill. This happens to be a 2.4, and I'm looking at mesial distal angulation, and then, of course, facial palatal angulation, and actually penetrating into available hard tissue. I'm always thinking tooth down in this situation in the upper jaw. I'm thinking, what is the tooth going to look like? Not so much where the implant is going to be positioned. Because if you can't idealize the position of the implant to maximize the emergence profile of the final aesthetic crown, you may have an aesthetic failure. So be very conscious of that. Again, I don't want to talk too much about implant placement, but here we made our osteotomy, and I'm going to take an implant and I'm going to simply thread it into position to the crest of the ridge. Now I need to widen that ridge to try to minimize that facial concavity that we created. And so by elevating that tissue, this happens to be an allograft material, again from Golden Dent. These products are, whether it be the instruments or the grafting material or the suture material, are very, very cost effective. And as a general dentist, I think that any savings that you can receive on the purchase side you can pass on to your patients, which is going to allow you to do more procedures without the patients balking. So again, look at what Kurt provides to you at the end of the program today. I think it's a product that I use every day in the practice. It's a high quality material from reputable sources. The instruments are very, very high quality, very well made. The membrane and the suture material are also something that I feel very comfortable using. So here I'm taking my allograft that I wetted with sterile saline. Never mix your allograft with anesthetic. The anesthetic has a very low pH, it's very acidic, which is going to affect your healing. So if any of you out there have had any issues of your graft not integrating properly and you use anesthetic, that may be one of the reasons. So the Goldas particulate, it's shaped like rice shaped, and it does have osteoinductive and osteoconductive properties, which allow for cellular growth. And in a very short amount of time, I would say a turnover is about 4 months. We know that when we do any type of graft material, we're not pouring concrete that gets hard. We know that we have a physiologic reaction where osteoclasts will invade, attack the surface of the graft material, and will stimulate osteoblasts to lay down new bone in a very, very short amount of time. Now, with any type of graft material, we must protect the graft from invagination of epithelium. Epithelium grows about 10 times faster than bone. So you must use a high quality membrane or barrier to protect the allograft material from invagination of epithelium. It's going to always be a race between bone growth and epithelium will always win. So we use a high quality membrane. And again, Golden Dent sells a couple of really nice materials. One is a synthetic and one is a xenograft material that they both work very, very well, and I use both in my practice. The important part of placing a membrane is that you place it properly. And even though I did not make a vertical incision into mucosa, I have complete control of this reflection, which allows me to control and pack my membrane beyond the facial defect of the site. And this membrane is placed very, very passively. You can see that I'm not forcing it, I'm not tugging it, I'm not ripping it, I'm not hoping that this membrane will stay in position. I know it's going to stay in position because I'm very passively placing it beyond the defect and folding it over onto the palatal aspect. One of the products that I like to use is called EpiGuide, and Kurt at the end will have specials. This is a synthetic membrane, 3-layer polylactic acid. It's very flexible but maintains its structural integrity. And I need a membrane that is going to last at least 6 weeks. Doctors, there's a lot of different products out there, and I know the sales reps are selling you and saying, oh, this is just as good. The question that I want you to ask them is, how long does it last? If they don't know, I wouldn't use it. The membrane has to last at least 6 weeks to be effective. What's nice about these products too is I don't need primary closure. So the use of all our membranes today, our longer lasting membranes, we do not need primary closure. That wasn't always the case years and years ago when we used our Gore-Tex material. We had to have primary closure. Well, that creates some issues, because how do you primary close certain sites without pulling the mucosal tissue onto the facial aspect of your surgical site? That's not appropriate today. So we don't use those materials. So we don't need primary closure, knowing that epithelium is going to grow 0.5 millimeter to 1 millimeter a day. And if we have a nice membrane, we can protect our graft material for at least 6 weeks. So you can see how I plumped out that tissue, that concavity that we had on the facial aspect with my allograft material and my membrane was passively placed onto the facial all the way onto the palatal surface. Now, the golden dent sutures are polyglycolic acid also. These are resorbable sutures of very high quality. I like to use a 1/2 or 3/8 diameter needle. These are reverse cutting needles. What I really like about the golden dent product is you're going to save a lot of money. Some of the PGA Vicryl materials can range in the $16 to $18 range, where Kurt has some wonderful specials. And every time you can save $5, $6 on a product in your procedures over the course of the year, it's a tremendous saving. This is a book that I recommend you get if you're not really proficient in suturing. It's diagrams. You can purchase it from Salvin Dental. Don't go to Amazon or Google. It's really expensive there. But if you go to Salvin, S-A-L-V-I-N Dental, they do sell this book, and I want to say it's like $100. But it's a really nice diagrammatic technique book that will help you get really comfortable in your suturing techniques. So there's a lot of different sutures out there. I like to use PGA, synthetic resorbable. The reason I like it is it does not absorb bacteria. And when it does resorb, it will resorb to water. So I don't see a lot of inflammation. However, I like to see all my surgical patients in a week to 10 days. The reason I like to do that is when you suture somebody, the patients will normally do very well. But 3 or 4 days later, if you don't explain to them, they will call your office and say to your staff, you know, I was doing really well and it's starting to bother me, something's wrong. And it's because we want to get closure. The epithelium wants to grow, but the sutures are preventing complete closure. So if I can see a patient in 7 to 10 days, then I can control the situation. I feel much more comfortable that healing is proper. A lot of us use silk. I don't really use silk very often in the practice because it's non-resorbable and it does create inflammation and it does absorb bacteria. Planar chromic gut are very inexpensive sutures, but again, sometimes I have problems controlling it and getting proper knots that don't release over a period of time. All our needles today that we use in dentistry are reverse cutting, which allows us to tie tight knots without ripping or tearing the tissue. Thread size is 3/0 to 6/0. I like to use 3 or 4/0 thread size. And again, I will have both the 3/8 circle and a 1/2 circle. So I would suggest if you're going to buy sutures today, use the 3/0 thread and get both 3/8 and 1/2 circle. Depending on the situation, you're going to want that diversity in your product. Now, this is really an important slide. Most of us, when we suture, when I'm teaching classes, live surgery, most of us were taught to suture from facial to palatal in this situation. And what often happens is if we have a membrane, our needle will actually penetrate through the membrane. We do get closure, but when the patient does come back and your staff removes the sutures, they will inadvertently remove the membrane. Now, I like to talk in concentric circles. That membrane must be intact for a minimum of 6 weeks. If you pull out that membrane in less than that time, or that membrane dislodges in less than that time, then the case becomes unpredictable. Now, I didn't say that it won't work. What I'm telling you is that I don't know if it's going to work. And it's very important for me, my time, the cost to the patient, that if we're going to do these procedures, that we're going to know that we are going to grow bone properly. So I'm going to have you take your reverse cutting needle, and I'm going to have you start from the crestal aspect and penetrate through to the facial, from the crest to the facial. So I'm sliding on top of my membrane rather than inadvertently going through the membrane. Now I'm going to turn that reverse cutting needle around, and I'm going to go from the crestal to the palatal. Again, I'm sliding over the top of that membrane, not engaging the membrane itself. So there's no risk of removing that membrane upon suture removal. The other very important part that I want to stop and slow down a little bit, when I placed my membrane, I placed it passively onto the facial, at least 2 millimeters beyond any defect, and I rested it and tucked it under the palatal reflection. So your surgical reflections are very, very important for your final success. Now I'm simply tying an interrupted suture. I tie a knot 2 loops forward, tie the knot, 1 loop in reverse, tie the knot, and 2 loops facial again or forward and tie the knot. These sutures will not come loose. They resorb to water. We don't get a lot of inflammation. Now, primary closure is nice, but it's more important that you look at the pink, the light pink zone of attached gingiva on the facial aspect of this site. You must have that. If you have mucosa, we may have to do a secondary procedure later on down the road. And then I will simply do another suture. I'm going from crest to facial, and then I looped it around. And this is a horizontal mattress suture where I engaged onto the facial aspect, and then I'm sliding it over to the palatal, and I simply tied my knot. Again, I don't have complete primary closure. I probably have 2 millimeters of exposure, but again, talking in concentric circles, epithelium is going to grow 0.5 millimeter to 1 millimeter a day, which will allow for primary closure in a very short amount of time. The implant in position, here the patient wore a flipper type of appliance that is not putting pressure on my surgical. Just tell the patient they won't even know that I did anything to. So technique is fairly basic and certainly something in your wheelhouse. It's certainly something that you can achieve in your practice. We have a short video. I'm not going to run the whole thing just for time. The book that I'd like you to get, you can get it on Google, called Principles of Dental Suturing from Lee Silverstein. It's a great schematic book of different suturing techniques. We're not going to go through every suturing technique available to you, but I'm going to show you the ones that I use most frequently. Before we begin, let's just look at our sutures. And in dentistry, we will use a 3/8 circle. This is what I use most often. We can use a 1/2 circle or a 5/8 circle. All the needles that we're using in dentistry that I use are reverse cutting, which means that we're not going to be tearing the tissue as we're suturing our attached gingiva. There are different types of suture techniques. These include an interrupted, which we will discuss. We'll talk about a modified interrupted. We'll do a continuous. Maybe we'll even do a continuous locking. We can do a continuous horizontal mattress, a vertical mattress, and a horizontal mattress. And I think if we go through those 7 techniques, we've demonstrated just about every application that you will use in your practice. So here today, we're going to use our 3/8 circle reverse cutting needle with a 3/0 plain gut. And remember, we talked about earlier the sizes of the thread goes from 1/0 to 10/0, with 10/0 being the smallest. So in dentistry, most of the time I will use either a 3/0 or a 4/0 suture. There are different types of suture material that we can discuss. First is silk. Silk is the most common. It's relatively inexpensive, and it ties a very, very nice knot. But remember that silk draws bacteria and needs to be removed in a short period of time because we will get some inflammation. Some of the polyester materials like PTFE, polytetrafluoroethylene, are braided, and they are lubricated to some extent, and these are non-resorbable. I guess we used to talk about Gore-Tex materials. They slide and they can untie sometimes. So it's a material that I don't use that much. Resorbable material, we're going to be using a resorbable here. Really, there's two basic categories: the plain gut, which unfortunately loses its strength after about 24 hours. And then chromic gut, which is treated with a chromium salt, will last up to 10 days. And I had mentioned in my lectures that I like to bring my patients back routinely, even if they have resorbable sutures, in 7 to 10 days to eliminate any inflammation, irritation, and just to check on the surgical site. What I use most often, and what you've seen in my lectures, are the synthetic materials, the PGA, polyglycolic acid materials. This is like Vicryl or Villet. These are hydrophobic. There's a slower rate of resorption from 3 weeks to 4 weeks. We get very, very mild tissue reaction, and they resist muscle pull. They also are very easy to use. They're a little more expensive than, say, the synthetic materials, than the polyester materials, or the resorbable plain gut or chromic gut, but that's what I use most often in my practice. So let's discuss different types of sutures. And what we'll do is you'll take your scalpel, and here I'm just using a disposable scalpel. And let's just take our work, be very careful with the sharp blade, and we will simply make a long incision here. Now, when you're making an incision in tissue, we want to make sure that we have a clean incision and try to make one pass. So you're going to go all the way to bone through the periosteum, and that allows us to make a clean incision without having to make multiple pass-throughs or multiple cuts. I mentioned in my lecture, we like to stay in attached gingiva. Even if we're doing vertical incisions, try not to go into the mucosal tissue. When we go into the mucosal tissue, we will create a lot of prostaglandin release, and the patients are very sore. Also, we lose control. We lose control of our relieved or our flap material, so it makes it a little bit more difficult to suture them closed. So we made an incision, and let's go ahead and let's practice on some of our techniques. So let's just do a simple suture. Now we have different types of suture holders. We can use a hemostat, which is in your kit, or just something fancier. But let's just do a simple interrupted to begin. In a simple interrupted, we call this the facial or buccal, and this the lingual. We go from facial through the tissue onto the lingual or palatal. Can't be any simpler than that. We'll leave a little bit of a tail. And what we'd like to do is we'd like to loop twice. 1, 2, grab onto the end of the tail and pull taut. And then do the same thing, 1, 2, taut. And then once backwards, just one, grab the tail and lock it in. And then we can take our scissors and simply, so we have an interrupted suture. Pretty basic, pretty simple, works very, very well. The second one we'd like to do is called a modified interrupted, where we will go from facial through the incision site, not onto the lingual or palatal, a little tail, and then simply reverse your needle and then go from the lingual or palatal through the incision line, not onto the facial. And this will kind of pull the incision together in the same technique, 2, 2, 1. Will give you a nice closure. This is referred to as a modified interrupted suture. And it's good to practice these techniques. They work very, very well. And then you can cut that. So that's called a modified interrupted. When we have a long incision, a continuous suture is often very, very helpful. So here we will do our same passage as if we were doing an interrupted, and we'll tie the knot as we did earlier. 2, 2, 1. And we'll simply cut the tail here. Leave the long part alone. And we're simply kind of going back and forth here from facial to lingual or palatal. And then just keep passing it through as if you were sewing. I'm sure a lot of us still darn socks today. And this will give you a very, very simple suture to get closure. And if we want to tie the knot to finish the line, this will leave that a little bit taller and simply same technique, 2, 2, 1. Of that suture. I don't use this type of continuous very often, but it will work very well and fits very quick. I'm going to stop there and so that we can demonstrate some more clinical cases of those sutures that we use routinely just about every day. Another maxillary anterior, you can see the decayed teeth that need extraction, non-restorable teeth. And again, this is not an extraction webinar per se, but I do want to demonstrate something that I'm very, very proud of, something that I would not practice without. I do love the Golden Dent instruments. They're very, very high quality. And what I'm doing is taking their periotome and just kind of going around the tooth, number one, to establish proper anesthesia, but also to loosen the periodontal ligament a little bit. And many of you are very familiar with the courses and the publications I've done using the Golden Dent Physics Forceps. I won't take too much time with this because you can review some of the past webinars, and Kurt can certainly discuss this with you. But it is a remarkable set of 4 instruments, a upper left, upper anterior, upper right, and a lower universal forceps. It has 2 components in it, what we call the beak and the bumper. The beak is the working end of the instrument, and it's simply a shovel-shaped edge that will be used to engage the lingual or palatal aspect of the tooth that you want to remove, 1 to 3 millimeters subgingival. The bumper is then placed as high up or as far down below the vestibule as possible. It is not the working end of the instrument, rather it simply serves as a fulcrum or a center of rotation. And then with no arm strength whatsoever and no squeezing of the instrument, I'm simply rotating my wrist, which creates tension on the palatal aspect of the tooth, and this creates energy, a physiologic response, which will release an enzyme by the body, which will break down the periodontal ligament. And we all know what holds that tooth in place is the periodontal ligament. If the periodontal ligament melts away, the tooth will then disengage up and out of the socket, following the arc of rotation of this precisely designed forceps. Again, and I say this sincerely, I would not practice without this instrument, and it makes my job of extracting teeth very atraumatic or minimally traumatic, and it does allow me to maintain facial plate of bone, which allows me to immediately place my implants quite predictably. So the beak is a shovel-shaped edge. The bumper, we can put a little silicone one-time use a bumper guard on it, which is soft and spongy, very simple to do. And I'm simply engaging the flattened beak onto the palatal aspect of this tooth, 1 to 3 millimeters subgingival, placing the bumper as high up the vestibule as possible, and simply rotating my wrist here towards, I guess it'd be the corner of the eye, not squeezing the handles whatsoever. In a matter of seconds, maybe a minute, this tooth will disengage up and out of the socket. The instrument is not intended to remove the tooth in total. Rather, it's intended to dislodge the tooth without squeezing. It's remarkable how atraumatic this is to the patient, in that because we're not squeezing the instrument, our patients are just amazed how we're able to take teeth out without a lot of pressure or discomfort or proprioception discomfort to them. I then take what we refer to as a tooth delivery instrument. It's a bird beak forceps, and I'm simply going to pull the tooth right out of the socket, maintaining the facial plate of bone miraculously. And here's a cuspid tooth. Again, you would think this would be a challenging tooth to remove, but again, I can remove this tooth in a matter of seconds, if not a minute. And again, this very long cuspid tooth is removed without complication. So something that you should look at. I know in the past we had courses at our dental school with the advent of COVID. Obviously, a lot of those courses have been delayed. But Kurt, I'm certain has many of my videos on YouTube that should allow you to become pretty proficient in the use of this instrument. Again, when we remove a tooth, it's important that we remove any granulation. So again, you're going to take a sharp curette, not one that you've had in your drawer forever. Get a surgical kit. If you're going to do surgery, make sure you have the proper tools. I'm going to curette, remove any granulation tissue. Purple blood is bad, red blood is good. I'm then taking my Orban knife or a scalpel, and again, I'm making that same envelope reflection. I'm not making vertical incisions whatsoever. And I can see that there is a facial defect on the lateral incisor here. I did not create it. Nature created it from the infection. And you can see the significant amount of granulation tissue that I'm scooping out of that site. I'm then going to, I am a big believer in immediately placing implants. Again, this is not an implant course, but I'm going to go through the process of determining my angulation, both mesial distally and facial palatally. I'm going to widen the osteotomy. Now, in this situation, I'm using a different type of graft material that's provided by Golden Dent. It's called the Osteogen plug. I strongly recommend that you invest in this material. It's relatively inexpensive, and it's something that I've done a lot of research, a lot of histology, and I do lecture and publish this material all around the country. It's a synthetic material. It's bioactive calcium apatite, which is the same bone building material of our natural bone. You do not need a membrane with this product, which is a very, very important advantage to using this material. The carrier is a bovine Achilles tendon, but the integrating material is calcium apatite. And it's not a collagen plug. Collagen plug is going to turn to snot. But what I will do is simply fill the socket. I will place it firmly, but I'm not packing it like amalgam, into my osteotomy site. And I can thread my implant directly into it. Now, what's going to happen is this material acts like caulking. And the implant itself is going to push the material onto the facial walls. We place the implant to the crest, and here we torqued it to 25 Newton centimeters, and then I'm going to do my second osteotomy. And it's, very important. Remember, my initial stabilities is from the apical 2 millimeters of my implants. And you can see we're actually harvesting the patient's own bone. We can mix that patient's own bone with another of this calcium apatite osteogen plug from Golden Dent, and I'm placing my second implant. I torqued it to position. The graft material acts like caulking. Now, on the lateral incisor, I still had a facial defect, right? With our allograft material, I said that it's imperative that we protect our allograft material from invagination of epithelium, because epithelium grows 10 times faster than bone. Well, in this situation, I also said that you don't need a membrane necessarily. We don't need a membrane when we have a facial wall of 4 millimeters or less. These are just rules that have worked very well. So in this situation, I'm putting cover screws. We're going to bury these implants. And I'm going to take a flattened piece of the osteogen material. It's a sheet, and this is the same material. It's very, very inexpensive for the doctor. And I'm going to use this as my membrane to protect the facial aspect. So I'm using one. You can use a regular membrane if you so desire, resorbable membrane. But here I used an osteogen sheet that became my facial wall. Suturing, again, is very, very, very precise and must be followed. Go from crest to facial. I did have a little vertical tear in the situation, so I'm correcting that first with my my horizontal mattress interrupted suture. I went from bone to facial, sliding over the membrane, and then reverse the needle and sliding over again to the distal aspect and tying a knot. And then again, my procedures are very, very predictable, from crest to facial, from crest to palatal, and I'm tying my knots. Simple interrupted sutures allow me to get closure. I don't have complete primary closure. I'm fine with that, because again, epithelium is going to grow 0.5 millimeter to 1 millimeter a day. We have to be very conscious of the band of attached gingiva. You can see that we do have pink attached gingiva on the facial aspect. If we lose that, we may have to do a secondary procedure in the future. Here we made a little snap it smile that does not press onto the surgical site, kind of rests on the teeth. 1 week post-op, you can see we don't have complete closure, but we don't have inflammation either. The material will set in place because it was passively placed, and the epithelium will grow very well in a very short amount of time into that site. I want to demonstrate 2 more cases, Lauren, with your permission, and then we'll give Kurt some time, and then we can take as much time as we want for questions. Here we have our implants placed, but you can see I don't have a band of attached gingiva. And so I'm going to run through this quickly, but I'm going to take my Orban knife, which gives me complete control, and I'm going to make an incision on the lingual aspect of the crest so that I can harvest at least a 2 millimeter band of attached gingiva that I'm going to move onto the facial aspect of my implants. So I'm just peeling it like an orange. The lingual tissue is still attached. I did not reflect that. I'm then going to place a tall healing abutment into my implant that's already integrated. This is a secondary procedure. I'm then engaging my reverse cutting needle. Here I'm going from the facial to the crestal area, and rather than engaging the lingual tissue at all, I'm simply going to go around that healing abutment. Lauren, you know this is simply a periodontal suture. I'm going around the healing abutment. I did not engage the lingual tissue. I'm going to reverse the needle on the distal and again wrap it around that tall healing abutment and tie my knot as we demonstrated. And now I've taken that 2 millimeter band of attached gingiva that used to be on the crestal lingual aspect of the surgical site, and I moved it to the facial aspect of my implant. 1 week post-op, you can see I now have a significant band of attached gingiva on the facial aspect of that healing abutment. This is a simple procedure. Doctors, if I left you with anything with this webinar today, I want you to be conscious of band of attached gingiva on the facial aspect of your implants. I'm going to stop. I'm going to do a really short video, Lauren, if that's okay, and then we'll give Kurt. I just want to show that mattress suturing that we did. I don't have a voiceover here. I placed 4 implants for a all-on-4 eventual final prosthesis. Here we did make a vertical incision at the midline, and I'm simply going to do an interrupted suture to close that. So I go through the tissue, two forward, tie your knot firmly. Now with the Vicryl, the PGA, you can see I have better control of tying that knot. It acts more like silk. You saw I was struggling a little bit with that orange with the gut suture because it doesn't tie really nice for me. So I really like the Vicryl or PGA from Golden Dent. And 221 or 212, always go in reverse. And I just closed that vertical incision that marked my midline, which allowed me to place the implants more predictably. And again, we'll just do that real quick here to tie that vertical incision that we made in the lip area. So now we're going to do a mattress. So I'm going from facial, trying to engage the attached gingiva if possible, and going to the lingual tissue. And I'm going to tie my knot just as we demonstrated earlier, 212 or 221, so that that knot does not come loose. You can see we get really nice primary closure here. And again, I'm just going to cut the tail. We're just cutting the tail. This is a real time saver when you have a wide incision to correct. Now I'm going from the facial to the lingual again. Now I'm going through the rabbit ears. You can see I'm going through the rabbit ears and pulling it through the rabbit ears. And this is called a continuous suture. And you can see in real time how fast this is from facial to lingual through the rabbit ears. Through the rabbit ears. And we're getting a nice closure of this site. And keep going until the very end. And with the PGA material, I'm not worried about things loosening or anything. I will see this patient in a week to remove the sutures. Go through the rabbit ears. And again, this is something you can really practice on an orange or a grapefruit or a lemon. It works very, very well. And when you get to the end, your loop will act as your tail. And you can see the time saving as opposed to doing complete interrupted sutures through the rabbit ears, almost to the end here, Lorne. And you can see I left the tail, the loop of the tail, and then 2, 2, 1. And then tie that off. And then I'll dab it. And you can see my primary closure on one side, my primary closure on both sides. 1 week post-op. I don't expect to get complete closure. But at this juncture, Lorne, I think I'm respecting everybody's time. If we can switch over to Kurt, maybe talk about some specials, and then we'll take as much time as we need for questions.
As I'm moving the screen over to Kurt, I realized that at the beginning I didn't even introduce him and talk about how lucky we are to work with Golden Dent on these webinars. Any of you who have ever put together a webinar know that these webinars don't come together on their own. It requires getting a great speaker like Tim in. It requires putting together the content, getting the invitation sent out. I've had the pleasure of working with Golden Dent for a number of years to put these webinars together. I'm very fortunate that we have such a great company to work with. They have such a great commitment to ongoing dental education. Another great reason that I love working with them is that they're always going to offer some type of special, as well as talk about some of the educational opportunities that are available to you. So at this point, I'm going to introduce Kurt Lawler from Golden Dent, who will do that, and then we'll get to the Q&A. So Kurt, take it away.
All right, I appreciate it, Lauren. My name is Kurt Lawler. I'm with Golden Dent here in Detroit. If you're not already familiar with our company, I know we get a lot of regular doctors that join our webinars each month, for a number of years. And if you're new, welcome. We appreciate it. We're a Detroit-based dental company that operates under the principles of providing simple, predictable, and unconventional type products. I had a customer the other day that mentioned we have products that you never really thought you needed, and you weren't really sure what they were, but once you try them, you always find that they add a lot of value to your practice. So we try to really find unconventional and unique ways of doing various procedures that are supported by the various products that we find. I'll mention the promo code first here before I go over a couple slides. We do offer a promotional discount for investing your time with us this evening. We appreciate you're here. Hope you enjoyed the content. And for this evening, the related to sutures, we have the code is Stitch 13. So it's STITCH and then the numeric 13. And that provides a 13% discount on our products, which is actually even better than the trade shows when we used to go to trade shows. It's been a while now, but that's a pretty good offer. It's not something we normally even do through email blasts and things like that. So I recommend taking advantage of it if there's anything you saw that you were interested in this evening. We do these deals that are good, but we do them, I guess, briefly. So the deal is good for 24 hours for anybody that's on live this evening. So it'll expire tomorrow, September 30th, the end of the day. And if you want to take advantage of that, like I said, it's a Stitch 13 for 24 hours. These are the sutures that Dr. Kosinski uses here at the top. I know he mentioned he doesn't use the black silk very often, but we do have those available too in our BioViva brand. Those are really inexpensive. They're like $18, or the pricing for the PGA 12 pack is $58, which Dr. Kosinski mentioned. It's actually a really good pricing. We spent a lot of time on these sutures, and the feedback's been great so far. So we do have a ton of these in stock, and if anybody's interested in trying them, we'd appreciate that. So for needle holders, we have all different types of ones. I'll show one here in a moment that's in our graft kit that Dr. Kosinski mentioned. It's more of an inexpensive type kit for $400 and some that has all of the instruments you need for grafting. However, we also do have these more higher end, really great needle holders and scissors that are available too. And what you'll see is there's this circle like right here that I'm showing is what's really popular with these hemostats is there's really no joint. So I know it's frustrating when you're suturing, when the suture gets snagged. These are designed to really not allow that to happen. And so there's a lot of videos and more information on these. I don't have time, obviously, to go through each one of these individually, but they are, each one is special. Some of them have cutters on them, allow you to have a cutter and a suture holder combo. The blades on them, or the tips, I should say, are never going to splay or expand over time. You'll see we kind of have an image there where it's actually holding a quarter. And when you take that quarter out, they do go back super tight. So these are really great sutures. You'll find, needle holders. You'll find those under our instrument section. Lots of videos to learn on those. We actually just added a thumb lock one too. Some of our customers asked for that, so you'll see them on there also. This is the simple kit. So you'll see obviously here's more simple needle holder. This kit also has the warband knife in it that was demonstrated quite a bit this evening. That's also available individually. These instruments are not expensive at all, but we made this nice kit just to keep everything together for grafting. So the plugs, this is a very, very popular product for us. It's a great product. If you're not offering grafting, this is a great way to get involved. It's pretty much as easy as placing a collagen plug, but it is a bone graft. If you're already grafting, it's also a great way to still have great clinical results, but maybe have more flexibility in your pricing and how much money you're spending on your graft materials, because it's only with the promo $43 a plug, and you do not need a membrane, which was demonstrated. So it's something to take a look at if you're not already using it, or if you're already using the product, you can obviously order some boxes with the deal this evening. This is our allograft. There's a lot of bone on the market. We've had this private label brand for a number of years now, our Gold Loss brand. Feedback's been great. We have it in a particulate and a putty. If you're using another brand, we'd obviously encourage you to take a look at our pricing and the clinical results. I think you'll be very happy with them. The EpiGuide, these are our two membranes. They're both long lasting. These are going to be the two that are recommended. The EpiGuide on the left is the one that is the most popular and the one that Dr. Kosinski uses. Physics forceps, I won't get into this too much. I know a lot of users are logged in this evening. This is the product that started our company in 2007. Still a great way to extract teeth. It's still the feedback we get still after, I think it's 13 years now, really, makes you feel good and knows that allows us to know that we're doing something special here. I mean, we really do get daily feedback still from doctors using our instruments, and just how it's really changed their practice, allowed them to feel more comfortable with extractions. Once you can do extractions, then you can start doing grafting, and it just leads to so much more. And we're very confident that this is still the best way to extract teeth. And this is the set called the Standard Series that we would always recommend starting out with. We have one more set that goes further back into the mouth. These are a little more technique sensitive. I would definitely start with the Standard Series set. If you're interested in this product at all, definitely look at this one first. There is a nice trial period on them, so you're not stuck with them if you're not happy for any reason. And then maybe look at these later on. This is totally off topic, but I just want to mention it since I know we have a lot of regular customers that join our webinars. Maybe our emails go into spam, or you just haven't quite seen this yet. But we did actually just launch a whole new Golden Dent Endo line, which we're actually very excited about. We've had great feedback. We've been working on this actually for geez, I think almost 2 years now, and we're finally have these products on the market. Motors, files, pins, posts, and we've got some great endo for the GP, CE offerings coming up, which I'll mention here. I think we have a webinar planned in early 2021 to start helping our fellow GPs with endo in their practice. So I'll just mention these really quickly because I know this is totally off topic, but again, I just like to mention this stuff when I have our captive audience here listening. The Woodpecker is a really great endo motor. You can learn more about it on our website, but we've clinically tested this one for a long time. I've got a lot more of these out right now being evaluated, and the feedback's been really amazing. It's a really, really great motor with a built-in apex locator. Something to take a look at if you're looking for a new motor for your endodontic procedures in your office. Just 1 or 2 more slides here. We have obviously fiber, metal posts, metal pins, even if you're using like TMS Coltine or Parapost or 3M or Pentron. The pricing is about 30% or 1/3 less than a lot of the market leaders. Really high quality products. These are not cheaply made by any means. Good comparison to these market leaders. There's even some clinical advantages. And I don't have time to get into them all right now, but if you want to go to our website, take a look. Another great product to take a look at. Then of course files. Right now we have the Pro Taper design. Ours is called Golden Taper. Obviously everybody has some sort of version of the more popular ones, which is in this case Pro Taper Gold. These are very comparable to those. Only $24. They come sterile in a blister pack, and that's very, very good pricing for these types of files. And it's not something you have to worry about from a quality perspective. Obviously nobody wants any files to break and have that nightmare. So we tested these for, like I said, a long time, and we're very confident it's a good product. So the next webinar we have coming up is November 10th. Just wanted to mention this. So we'll send a link when we send the email with the replay link for this webinar. And then I have one, hopefully this isn't news to Tim, but I have one December 8th. Still topic to be determined, but I have kind of a placeholder for the next one is December 8th. And then finally in February 2nd, which I know is a ways out, but it'll be here before we know it. That's when we're doing our first endo for the GP program. So that is available and up on the website now if you wanted to register. And I will leave it at that with the promo code here and turn it back to Lauren for the Q&A session. And I appreciate everybody's time this evening.
Thank you, Kurt. We appreciate that, and I certainly would encourage people to take advantage of these specials. As Kurt mentioned, they're limited time. Don't call them up next week and say, "Hey, I'm ready for that special," because it won't be there. But they've got great return policies, and you really have nothing to lose. Tim, you ready for some questions here?
Absolutely, Lauren.
Okay, let's see. One that came in actually before the webinar started. For a doctor that had placed 5 implants, they have 1 pending on 19 that will need some grafting on the buccal bone for better width. How do you determine when to do grafting first, heal, and then place the implant versus place the implant and graft along at the same time?
Wow, that's an intense question. I like doing immediate. I like doing immediate implants in an extraction site. However, if there is purulence, if there's an infected area, or if you're not sure that you can get all the granulation out, I will not put my implant in immediately. But I don't have a problem of grafting that site, Lauren. And I like to use the analogy of a hangnail. For those of you who've ever had a hangnail on your big toe, you're miserable. You can't walk. It's so painful. You soak your foot, you clip it, 5 minutes later, you forgot that you even had the pain there. The body's an amazing thing. Bone heals from the apex towards the crest. So if there's any type of infection in an area, I'd rather that I graft and then go back at a future date, a couple, 3 months, to place the implant. I can grow facial bone around an implant very predictably. Again, we demonstrated the technique a little bit. When we're grafting a facial defect, I will normally use an allograft material, but we must protect that allograft from invagination of epithelium. It's just physiologic. So the membrane must be placed passively It must be placed at least 2 millimeters beyond any defect, and it has to stay in the mouth for at least 6 weeks. So you need a longer lasting membrane product to be able to achieve the results. If we have a defect post implant, the implant's placed and we have a facial defect, it is very, very, very difficult to repair that site predictably. It's very, very challenging to repair that site predictably. You must have bleeding. You can try, but I'd rather that we start with a good foundation rather than trying to, with building a new house, start with a good foundation rather than trying to prop something up later. So it's a very good question. It's a very, very, very tricky question to answer. So I'd rather that we do it all ahead of time if we can.
Okay. And I know this may be a difficult question to answer because obviously there's a lot of variables, but if someone's got a relatively large multiple extraction site incisions, let's say from bicuspid to bicuspid, is there a preferred suture that you would use for such a large area like that? Just either from an efficiency standpoint or...
I would use the mattress suture that I demonstrated at the very end, just for sake of time. If you don't feel comfortable with it or not proficient, interrupted are fine, but doing interrupted sutures just takes a long, long time. So I love that mattress suture from ear to ear type of incisions. And I usually do half and half. You know, I don't carry it all the way around. I'll go from midline back and then midline back.
Okay. If someone was trying to preserve a socket with, say, something like NovaBone putty, how do you secure the graft? Can you use a collagen plug with sutures? Can you use like a PRF membrane and suture? What's the best way to deal with that?
It all depends. If it's just a socket, then I would cover it over. I would cut like a little manhole cover of that osteogen material and lay it on top. The important thing to remember is epithelium grows 10 times faster than bone. Bone heals from the apex towards the crest. Epithelium goes from the crest into the socket. Epithelium is always going to win. So if you can protect it with a resorbable membrane, I'm not a big collagen plug person because collagen plug turns to snot in a couple days to a week to 10 days. I need to protect it for at least 6 weeks to get proper integration and predictability. That's the key. You're going to do this. You're spending money and time, or the patient's spending money and you're spending time. You want it to be predictable.
Yep, that makes sense. Okay, when you place the implant with the osteoplug, is the stability still within the bone, or is it because the osteoplug is putting pressure on the implant, holding it in place?
No, the initial stability of our implant systems today are in the apical 2 millimeters. So the graft material is just caulking. It's just going to fill in, bone's going to, osteoclasts are going to eat it away and lay down new bone. So I don't get a resorption on the facial aspect.
Okay. When you use that flat piece of osteogen as a membrane, do you charge out a graft and a membrane or just a graft?
Well, no, I would just charge out the graft. The material is $40 if you buy it from Golden Dent, $45. So it's not like a big investment like an allograft would be $110 just to buy it, and a membrane is another $110. So I would just charge for my graft procedure and just do it all.
Okay. So are you typically recommending non-resorbable sutures or resorbable more often than not?
Well, I use the PGA, which is resorbable. I rarely use non-resorbable, but I like to remove my sutures in a week to 10 days.
Okay. This is a good question here. As a beginner to grafting, I've heard over and over again how important primary closure is. In some of your slides, obviously you couldn't achieve it and didn't feel it was that was all that critical. So how do you where's the justification if it's different than what there people are learning in dental schools?
You don't need primary closure as long as you're protecting it with a membrane that's going to last at least 6 weeks. Okay. We can grow bone very, very predictably today, but it's technique sensitive and you have to follow the recipe. You can't take any shortcuts.
I know you showed some of the physics forceps, one that was using the wrist rotation. Was there a specific name for that one that you showed in the slide?
The standard, it's a standard set. I think that was an upper left.
Okay.
Because
It's the standard. It's part of the standard set, though.
Part of the standard set, yeah.
Okay. When you were showing the suturing technique, you kept using the term "through the rabbit ears." I think a couple of people may have been a little confused about what exactly you were trying to get across with that concept.
Well, remember how we learned how to tie shoes, right? So I initially made an interrupted suture and a knot, right? Then when I passed from the facial to the lingual on that case, rather than bringing it straight across, we had a circle there, and I'm bringing it in through that circle, or the rabbit ears, like you're tying your shoes, bringing that through, and that will tie the knot and bring the tissue together. Again, that book is really helpful, and practicing on an orange is really helpful. It's a really simple suture technique to do, but you just have to practice it.
Okay. Yeah. Speaking about the suturing, when you did that, the 2-2-1 or the 2-1-2, which one's reversed? Is it always the second loop?
It doesn't matter. As long as you do 2 forward and 1 back, the knot will not come loose.
Okay. EpiGuide versus CollaGuide. Do you have a preference? Are there certain indications for one versus another?
To be honest with you, no. I think the EpiGuide in my hands handles really well. We all get used to certain products that we use for a long time, and just the way it lays, it's a synthetic material rather than being a xenograft from an animal, obviously. But I use both, and they both work equally well.
Okay. If you're not going to be doing bone grafting at the time of extraction, how long would you normally wait? If you have to go back in, if you're going to do it as a second stage procedure, what would be your typical time frame before grafting? Going back in? To be honest,
Lorne, if I was taking a tooth out, I would always graft. If I knew it was a site that I may potentially want to place an implant in the future, I know a lot of our oral surgery colleagues will extract and then come back at a future date and graft it. Because they can, for insurance purposes, because they can bill it out a little bit differently. But to put a patient,
you'd also mentioned there's some cases where if it was like an active infection or whatever, that you wouldn't typically graft on that appointment.
I don't really have a problem. If as long as I can remove most of the granulation and purulence, I don't have a problem grafting the site. I just have a problem placing an implant in that site.
Got it. Yeah. Okay. What do you think about using PRP as the only membrane when grafting?
Perfect. No problem. Do it all the time.
Okay. We only have a couple more questions here, which I'm surprised we're getting to the end here. Does anyone still make a non-resorbable membrane? I mean, when I started grafting, all we had was Gore-Tex, so they all had to come out. But
there are. Yes, they are. Yeah, of course there are. The companies make. I just don't use it because the resorbable membranes we use last anywhere from 3 to 6 months. I only need it to last 6 weeks, and I don't need primary closure with it. So in my practice, there's no need for me to use a non-resorbable membrane. I don't need to inventory that in my practice.
Okay. Let's see, a couple more questions here. Saw an X-ray with a restoration on metal on the socket, probably amalgam. Patient said they had a bone graft when the tooth was taken out and had a big amalgam filling on it. Should the piece of amalgam be removed before implant placement?
Ideally, yes. It's sometimes with our two-dimensional X-ray, you don't exactly know where that amalgam is. That amalgam, it could be a tattoo, it could be embedded. I would hate to remove a big chunk of bone to get that little piece of amalgam if it's been there for a while. It's a great question.
Okay. The final one's more of a comment than a question, and I've been doing these webinars with Golden Dent for years now. This may be the best question I've ever seen, a comment. They said, I made the incision in the orange as you demonstrated. Then I remembered I missed lunch, so I finished cutting the orange and ate it. Guess I'll need to practice on live targets. Food makes me hungry. Thank you for a terrific program. Golden Dent products are great.
You should give that to Kurt as a marketing comment.
That is great.
Bye.
Well, we want to be respectful of people's time. We know that apparently there's other stuff on TV now that might be worth watching. So, Tim, you want to just say some closing words, and then we'll close it up for the evening.
Well, as always, I always appreciate working with you, Lorne. You're such a professional, and I really enjoy this. I know I talk fast, but we try to get as much information, at least to stimulate the thought process, and that's what we're trying to do today. Is just let's all get better, let's all stay safe and healthy, and be successful. So thank you, Lorne.
Well, thank you, Tim. You know, I've done dozens of these webinars with you. One of the great things, for those of you who haven't been on the previous 20 or 30 that we've done, is that there's no regurgitation. You're not seeing the same cases, the same slides. It's all new stuff. So for those of you who are asking, there is a recording of this webinar. I'm going to get that off to Golden Dental sometime this evening. Normally that goes out within 24 to 48 hours. So in case you came late, or if you're hearing this recorded, then I guess you'll if you miss some of it, but it will go out. For the CE credits, when you log out, there's not going to be a test. There's nothing you need to do. As long as you were here for the webinar, you're here live, you will get that CE. We had, as I mentioned at the beginning, close to 1,600 people registered. So that oftentimes can take a couple of weeks to get out to everybody. Please be patient. But if you haven't got it in a few weeks, feel free to drop me a line, and I'll certainly check into that as well. For those of you who are planning to take advantage of this special, as I mentioned, this is a fantastic deal. I don't think I've ever seen them do this big of a deal on any of the promos. It's certainly more than they do at any of the trade shows. Take advantage of it. It's a limited time offer. So as I said, from my knowledge, have many clients that work with Golden Dent. They have a great return policy. If it's really not the right product for you, you'll get your money back. But this is a superb time to try out their products if you haven't already. We thank Golden Dent for their continuing support of these webinars, of bringing in people like Dr. Kosinski, and making sure that everyone knows about the webinars. As Kurt had mentioned, we do these on a regular basis. We got another one coming up in a few weeks. We actually got another 3 or 4 scheduled between now and February. So all of you who are here this evening will certainly be sent invitations for those future webinars. Thank you all for your time. We know it's valuable. Hopefully this was something that you found some good value in. And we look forward to seeing all of you on future webinars. Good night, everyone.